Welcome back. The session is called Breaking Tradition, Non-Femoral Access in the Leadless Era. And we have a case presentation from Dr. Mikhael El-Chami from Emory University Hospital in Atlanta. First, let's meet our panel. Nicholas Olson from La Jolla and Usman Siddiqui from Orlando. Mikhael, I'll give it over to you. Mikhael, I think you're muted.
Am I muted? I don't think so. All right. Sorry about that. Let me get back. Okay. So I was asked to show a case of an IJ access, but first I'll have a short presentation. These are my disclosures. So why IJ access? If you think about it, and if you look at this cartoon on the left side of the slide, you can see that the IJ is almost always a straight trajectory to the right atrium. And it also allows you to cross the to have an anterior trajectory with easier access to cross the tricuspid valve and point to the septum. And since we almost always want to avoid the apex, the IJ access allow you a probably safer implant as opposed to a femoral implantation. In addition, it is potentially associated with lower access complications, as I will show you, maybe because the IJ is easier to compress, and it allows the patient for early ambulation. So when do we use the IJ route? I will show you after this two cases where the IJ route was very helpful. But if you think about the next patient that you have who might have a severely enlarged RA and RV, and especially if you're talking about the time-based fixation leadless device, you have to have adequate contact before you release the device. And in the patients with very large RA and RV, sometimes as you try to push across the septum, the device bounces upward in the right atrium and you don't have adequate contact. And also in patients with a small right atrium, it might be very difficult to maneuver and cross the tricuspid valve. So the IJ route might be safer. And third, in patients with TTVR, it might be much safer to cross from the IJ route as you will be directed straight to the septum and you don't have to navigate across the valve. And obviously you have the obvious reasons in patients who have IVC occlusion or severe tortuosities, they might benefit from non-femoral access. I will show you the first case. This is a referral to our center from very experienced electrophysiologists in town. This is a patient with rheumatic heart disease who had a pacemaker on the right side and presented with a fractured RV lead. As you see here, the lead is truncated, and he had complete heart block. So originally, the implanting physician tried to put an RV lead from the left subclavian vein. And despite using a coronary sinus sheath, he couldn't get a stable lead in the RV. He went back and tried to do a right femoral micra. And this thing that I talked about in patients with dilated RV and RA happened to him. Anytime he tried to get adequate contact, the delivery system bounced back. So he tried again and ended up, the only thing he could put, and I don't know if it'll show up here, a quadripolar LV lead and program the device VOO. The patient came back with intermittent loss of capture. The physician tried again and failed. So he sent the patient to me and said, maybe if you try an IJ access, you could get adequate contact. And the cine of the heart, like I couldn't get the entire heart in the same cine, but you can see here delivering the device high up in the septum, maybe even the RVOT area. And this is the device you can see here in the cine. You can even get the entire RA and RV in the same picture. So we had excellent contact. Obviously, we got directed to the high septum, but that's relatively common with the IJ access. And then we extracted the redundant leads after that. A second case also referred by another EP in town, dialysis patient, complete heart block, couldn't cross the tricuspid valve coming from the femoral area. Also, they couldn't put a diagnostic catheter to pace the RV from, couldn't cross the tricuspid valve simply by using a diagnostic catheter. So they did an MRI. And you can see here the SVC goes straight into the RA. But if you look at the IVC, it almost has a 90-degree angulation into the RA. And which probably what made the procedure very challenging for them. And this is us doing an IJ micra. We have a Mullins sheath, which help us cross the tricuspid valve from the leg. And then we navigated across the valve relatively easy and ended up placing the micra in the anterior apex or anterior septum, sorry. So these are two situations where an IJ access was very helpful in implanting a leadless device. A third potential area where the IJ access could help is when you have a TTVR. Because when you're coming from the femoral area, especially some prostheses are extremely large, and it's hard to fight the prosthesis and go septed. So what is the data behind the IJ access? It's basically the largest series is from The Hague, Dr. Salim Talib. She presented their early experience a few years ago. 82 patients, mean age 80, 71% with one deployment only, one pericardial effusion, one dislodgement as complication. And then 2 years later, a multi-center study where you had a leadless pacemaker implantation or describing the experience of the IJ access, comparing outcome of 100 IJ versus 100 femoral implantation. As the IJ implantation was associated with lower procedure time, lower complication, especially access complication, and easier ambulation for the patient and easier anatomical access to the right ventricle. And as I mentioned before, the IJ approach could get you higher on the septal location. You might have to accept high septal location, which I think is okay. And you see this in 25% of IJ approach. And this is a diagram from the presentation showing you how the superior vena cava leads to more anterior access into the RA, allowing you easier to cross the tricuspid valve and aim to the septum as opposed to the IVC. And since the femoral access, we always aim for a gooseneck appearance. I think maybe Dr. Talib came up with the reverse flamingo ankle appearance that when you're coming from the IJ. So this is the setup. You see how we tilt the camera sideways to allow free movement along by the head area. We use usually a small table here and a large table here, or you can just use one table and put it perpendicular to the X-ray table. Now, the case I will show you, we didn't do this. The case that I show you was maybe the third or fourth case that we've done IJ early on in our experience. And now we'll show you a recorded case. This is a patient, 85-year-old, long-standing persistent AFib, structural heart disease, but preserved EF, multiple admissions for atrial fibrillation with RVR despite beta blocker, DIG, and calcium channel blocker. So we elected for a IJ, micra, and AV node ablation. So if we can play the case, which is around 10 minutes, that would be great.
So welcome to Emory University Hospital, Midtown. Have here our EP team, including our fellow Dr. Kapoor. And we're performing today a right IJ micra along with an AV node ablation. So we're going to perform this device via the IJ access. We already obtained IJ access using ultrasound guidance. And now we're going to exchange the 8 French sheath with a 16 French sheath to dilate our access point. The main issue with the IJ access is the way you sit at the top of the table is a bit challenging. Dr. Kapoor here is advancing the wire, and I'm going to verify the location on fluoro. We try to get it down in the IVC, so you can advance it here. Sometimes, especially with the stiff wire, you're gonna need like an MP to get it in the IVC. Can we get an MP catheter? Causing ectopy here. I'm just going to use the MP to try to direct my wire down in the IVC. So advance it. Advance your MP here. Advance it. So I'm gonna see if it. Uh, here. So we got it in the IVC. That will act a better rail, I believe. So yeah, you wanna pull the MP out, but we have to keep. Okay. Now we're gonna have to go with the micro sheath. We dilated with the 16. So the key is to go coaxial, but don't go like this. Just go coaxial with it. Mm-hmm. All right. Here. Okay. So here, well, we need to look under X-ray. Okay. 1 second. See, make sure you look. You have to go coaxial. Is it going? Okay. No. Resistance or no? Uh-huh. Let me see. Okay. Just try again. Yeah. Okay, let me try it for a second. Mm-hmm. Alright.
Would it help you if I swung this?
Yeah, maybe. Laura. Just keep it for now. Yeah, it's tough here. Okay, think. Mm-hmm. Yeah. I don't know if it's the neck per se.
Or more wet, make it more wet.
Yeah. All right, give me some wet. Are we doing okay there?
So this is a bit harder than normal, by the way, but it's good to show.
No, I'm not available right now. He has to wait for me. All right, Flora. So this is a bit tougher than I'm used to, but at least we got it down. Can we get the... Okay, so that's why I wanted to get the wire in the IVC just to give me a rail. So you see there. Okay, so now you can come here. We have to try. Okay, I need someone to fluoro for me. All right. Okay. Okay. So, okay, hold it. Hold it. Hold it. Don't let me move it. Okay. Okay. Stay like this for a second. All right. So we need to
It's always wonderful
unsheath.
to
So can you
always
unsheath
in
it? Like fix your micra and unsheath fluoro. Okay. Hmm. Okay.
I think it's almost always
I'm-
more stressful with
It's
fellow.
hard to maneuver. See how
I will give you
it's,
credit. You're the only one that has had a fellow do the quarter case for the U.S. Focus today. So kudos to you.
Okay, I think that's gonna cross.
Maybe it was a mistake.
Anesthesia for these
XP.
cases, Mikhael.
Yeah, here's one.
You know,
Can
the
we go
first
in?
two
Yeah,
or
it's
three
here
we did
too.
use anesthesia,
RIO.
but then now we don't. We use MAC.
Alright.
Just sedation.
Then take me a little
Okay.
bit.
Yeah, MAC sedation.
After the recent
Fluoro.
effort in the ablation world about utilization with large bore sheaths and the use of sedation, you find that then to try to use general anesthesia for these cases?
I have it
Uh,
actually, Cine.
Not really. I mean, for these leadless devices, usually they're pretty fast. The only reason we use anesthesia is we thought early in our experience, comfort. You see us here injecting dye. And really, the hardest part of this procedure is getting the sheath down. But there was one deployment, if you look at it here. And you see here the flamingo, reverse flamingo appearance.
Okay. Just have it ready, Fluoro. Uh-huh.
I feel like the room setup is
Okay.
half the battle in these
Yes,
cases.
I'm on lock.
We've gone
Yeah.
to
Have
putting a
the
large table at the patient's head so that we can lay the catheter out
causing
and
sensitivity
sheath
with the delivery
straight
system.
superiorly, bending around and always worry about contamination. I think that's been a helpful transition that we've learned.
Tethers.
Yeah, I mean, you can see here our sheath will move in a second. You will see it, but that was like third case that we did. We didn't have a lot of experience, but I think the setup is very important, as you mentioned. Otherwise, the procedure is very fast.
That is one of the things. It's such a hydrophilic sheet, right? It tends to slip out.
Yeah.
So it's one of the
Yeah.
things you have to like be very careful about, especially if now you're using the micro. But if say you're using the shorter, if you're using a
Okay.
VAR and you're using a shorter sheet, the 30 sheet, that's one of the things you have to be so cautious and careful about.
Yeah.
Is the sheet will slip out.
Here we're showing, you know, when you have good contact, it's like anything, like a watchman. Even when you see this bouncing back of the tethers, you know, it's a good sign that you have good contact. But yeah, I think, I don't know if it showed, but
Threshold is 0.38, so we're ready to release.
we all, you know, one time the sheath slipped down, but it luckily didn't. Nothing happened.
Tight as each other. Maybe this is tighter. Okay, cut it. Come on. The other way.
I have to say that our setup is a little bit different.
So I'm gonna start.
I stand on the right side and move the eyes around because I'm just so right-handed.
Can you
Yeah.
Not as skilled as you are.
I mean, the issue is like I always have to put the fellow between me and the X-ray, so I'm standing there. But no, we have changed our setup. And this was early on, but you're right. Yeah, the table is sideways, like Nick said, and we're standing by the head more than here.
We're gonna take 12 French sheath. Can we have the ablation catheter?
So now we have to do the AV node ablation. I won't show you the struggles because we did struggle with the AV node ablation, but you know, it was you know, couple of, I think the AV node ablation took us as long as the micro itself. See here,
Can
the
you
sheet
walk us through
slip.
your sheet? Yep. I just saw that. What's your vascular closure strategy? Like, how are you getting hemostasis?
So for this one in particular, we did the figure of 8, but we're using a lot of perclose, 1 or 2 percloses. I feel like in the neck, the figure of 8s helps also because, you know, there'll be like a decent size kind of opening. And if you do a figure of 8, it helps it helps the skin heal. But this is the AV node. Like it took us more than once to get it, but this has had the appearance in LAO here. And we gotta, you see the heart rate soon will be 40, paced at 40. I use the figure of 8 or the perclose. How about you guys? What are you using for those?
So
I like
I've
to
been
use the
using double
perclose
perclose,
device.
but then yeah, I'm using double perclose, but I actually do this figure of 8 on top of it, just for the reason you mentioned, to bring the skin together. I just, you know, it's especially if the patient's awake, having somebody hold their neck for 15, 20 minutes becomes uncomfortable for them. So we started using perclose for that, but still do
Yeah.
figure of 8 on top of that.
The thing that helps here, or what's amazing, is you just pull the head at 45 degrees, and that will also help hemostasis because it drops the venous pressure. And it's really like amazing because you do a microactivation, basically can walk off the table after you just hold a little bit of pressure by the neck.
I've done a double perclose. I've learned completely that just tilting the head up and getting the venous pressure down is really helpful, especially, you know, folks that might have a really high venous pressure, like a dialysis patient or someone who has some significant right-sided heart failure. But putting a little, if I do get hemostasis with the perclose devices, just for cosmetic reasons, I just used a little bit of Dermabond, and that usually can juxtapose that skin right over the site, and it has a much better cosmetic appearance. I think patients
Yeah,
like that. So I've been recently
that's a good idea.
pretty successful.
For both of you, question like how, because I still like, despite having enough experience with IJ, it's still probably a smaller percentage of all the leadless. It hasn't made it to become like more common use. How, I'm curious, what are you guys doing? Are you doing more IJs as you get more comfortable with it, or is it just for exceptions? How about you, Nick? Because we
Yeah,
lost Dev.
so that's a good question. Initially, just like micro, I think we first started doing it only the patient that we absolutely couldn't put a transvenous device in. And then now we've kind of switched over to this. My view is consider a micro on everybody, and then convince myself it's not a good idea. And I think that there's just a lot of advantages to doing the jugular approach. I think, just as you alluded to, the consistency of the straight shot to the right ventricle. The problem is usually femoral approaches just go so smoothly. It's hard to transition out of something that goes so well.
Yeah.
But I think a couple of things in the future. You know, uh, an example. Percutaneous tricuspid valves, structural interventions. I do think that in your example and in one of your case examples, anytime it's just, I think that there's more risk sometimes coming from the femoral, because as you come across the tricuspid valve in certain patients, there's just this natural tendency to go right into the free wall with the catheter bouncing off
Yeah.
the septum. And that is minimized quite a bit by coming from the IJ approach. I do think it's, honestly, the biggest reluctance is just the setup. The lab doesn't really familiar with it. It takes time to switch the camera around. But I think if you take the time to do that, I think you will ultimately save yourself some time. And I know we don't have probably time to go into it, but I do think in the future, with leadless technology, as we move into concepts of conduction pacing, I think there's going to be some advantage to becoming familiar with the IJ approach, and not just doing it on those ones that fail us. I think we'll do ourselves some service. So I'm actually considering going to an IJ first approach. I haven't tackled that yet, but thinking about it during the session today, I might transition to that.
Yeah. The group from The Hague has done that transition. I think now like 3-4 years ago, and they have very good experience and low complication rate. I think convincing the staff to change the setup, especially that, 80-90% of the time you do a leadless from the groin, it's just so fast and so easy. But it's so those 10% of cases or 15% of cases where you struggle to cross the valve or you bounce off the free wall, like you said, these are the one that makes you nervous and you wish you went IJ. But it's a mindset. I think you have to change your mindset. Plus, Vivek Reddy mentioned that in the session before, or yesterday, with all the newer technology, and you just mentioned it, the conduction system pacing, the newer maybe Medtronic single capsule DDD device. You probably have to go from the IJ, and then we'll give you the choice, probably just maybe also one groin access for the eyes if you decide to use eyes. But I think we're probably going to make that leap and change in the next year or two. But for now, to me, it remains an exception rather than in all comers.
I will say that in the first in human implants for the Avera CSP, all of them were IJ. And the current delivery catheter is only designed for IJ, and same thing would be for the micro DDD as well. But I'm wondering whether is that going to be an onus on the operators to learn IJ, or will it be an onus on industry to develop delivery systems for CSP leadless from the groin? Who does that onus go to? But like you said, I think it's an easy approach into the ventricle. I mean, I'll tell you, like you'll struggle from the groin, and then I'll call it and say we're going to the neck, and it'll be quick. The
Yeah.
case goes quick. it's those, but it's that hesitancy that we have for the setup. We're used to something, and also convincing the patient that we're going through the neck.
Yeah. I mean, you saw us struggling pushing this 27 French sheath in the neck. I mean, that's, like it takes a while to get used to that, and definitely not an easier transition early on. But like you said, it's a seamless transition. And, at least I mean, Aver has a shorter sheath, which probably help. Maybe you have more experience with it than all of us, Devi, but the Micra sheath is still very long and it's a little bit clunky. So maybe if we have a shorter introducer, that's also will add another, make the procedure even easier.
Yeah, for sure. I think with the Aver, if it's a neck implant, I only use a shorter sheath because it just sits better. You don't have to bend around like you had it bent. But as I said, there's also the other side of it. You have to be so watchful of the sheath not slipping out as well because of the way it sits and how we do it. But having said that, Mikhael, I think we have run out of time. 30 minutes goes by very quickly. Our thanks to you for an excellent case and taking us through this new approach that we might be seeing. And thank you, Nicholas, for joining us and for your thoughts. Stay with us. There's still plenty more to come on our US Focus Day 1.
Thank you, Debbie.